those of you who don't know me, my name is Bhikhu Kotecha. I'm an ENT consultant, and I have an interest in sleep medicine. I have worked at the Royal National Throat Nose and Ear Hospital for more than 25 years, where I specialized in sleep medicine. So today's topic, neuromuscular electrical stimulation in OSA, a new technology to meet today's challenges in UK. Next slide, please. And next. So when we look at the prevalence of obstructive sleep apnea, we know that this condition is extremely common, but quite often it's unrecognized. And looking at different papers in the literature, there is a significant variation in the prevalence, ranging from 9 to 38% in Senratna's paper in 2017. We did a study, Matt Lechner, my registrar then, and we combined this with the Stanford group and looked at the changes in prevalence over the 2 decades. So this has doubled. Atul Malhotra's group, the report by Benjafield in the Lancet, also showed the evidence that the global incidence or the global occurrence of OSA is 1 billion. They looked at 17 different countries. The important point here, however, is that untreated OSA will result in a huge health economical burden. Next slide, please. So the NHS in the UK has got issues, and I'd like you to refer to this paper by a friend and colleague of mine, Kostas Haitis from Oxford, who looked at the distribution of sleep services and the funding for different services like CPAP, oral appliances and surgery within different clinical commissioning groups. And the policies were evaluated and the differences were seen. With CPAP, it was available everywhere, but the other treatments were not available. So they've looked at the cost effectiveness of various treatments against no treatment, and this is indeed very interesting. The NHS has issues with costs, funding, waiting list, and staffing. And the waiting list in this recent pandemic has been even worse from 2020 onwards. Next slide, please. So I was very fortunate to be invited on the panel as a topic expert for the NICE guidelines on OSA, and this was between 2018 and 2021. And to summarize some of the findings, the CPAP therapy has been always recommended for moderate and severe OSA, and this was indeed from 2008 onwards. But for mild symptomatic OSA patients, CPAP therapy should be used. But if the patients decline CPAP or are not tolerating CPAP, then they should be offered an alternative. And this may be in the form of the positional modifier, or it may be in the form of oral appliances such as a mandibular advancement device. And certainly for patients who can't tolerate CPAP, and particularly for the moderate and the severe ones, they should be referred to ENT surgeons for considering oropharyngeal surgery. Next slide, please. So we know that sleep medicine is a multidisciplinary field, and it attracts physicians, chest physicians, maxillofacial surgeons, ENT surgeons, dental surgeons, and the ENT involvement is specifically useful for evaluating and treating the obstructive upper airway. We've reported on this and offered some help in the paper that we wrote in Journal of Thoracic Diseases when CPAP fails. Next slide, please. So when we talk about neuromuscular electrical stimulation in OSA, perhaps the first thing that jumps to our mind, specific as a surgeon, is the invasive direct hypoglossal nerve stimulation. Now, this has been available for the last 2 decades, but it is extremely invasive. It is not widely available. And so for this reason, people have looked at non-invasive electrical stimulation. And initially, there have been reports on transcutaneous electrical stimulation during sleep, but this again would perhaps disturb sleep. So tonight's focus is going to be on the non-invasive neuromuscular electrical stimulation during wakefulness. And that brings us to the topic of Excite OSA, a very novel, recently introduced device. Next slide, please. So I'd like to share my experience with Excite OSA along with all the participants. And I was involved in the earlier studies, and I've been working on it as an investigator between 2018 and 2021. And this was when I was an ENT consultant both at the Royal National Throat Nose and Ear Hospital and Queen's Hospital. I've also been involved in a multicentral trial between UK and Spain, and I'd like to share some of the data with you. Next slide, please. So the device itself is a combination of a washable, flexible mouthpiece. There are electrical stimulators, 4 of them, 2 above and 2 below the tongue. There's a rechargeable unit with a USB port. And there's a smartphone app, which we'll show you in a minute. And the stimulation, the current delivered can be adjusted according to the tolerance of the patient. Next slide, please. Here you have a patient with the device inside you. You can see the iPhone there, and it's a very clever device. It'll time you, it'll increase the intensity as and when required. Next slide, please. So here you can see the video on different intensity. You can see the stimulation of the tongue muscles at different levels, 3, 6, 12, and 15. Next slide, please. So I just wanted to concentrate on some of the results. There have been numerous studies that have been done. I've been involved in a couple of them, and I'm going to share the data that we had published in last March. Next slide, please. So we looked at 70 patients. Of the 70 patients, 38 had mild OSA, 32 had simple or primary snoring. And we looked at watch pack studies. This was done for 2 nights before and 2 nights after the treatment. We looked at the objective reduction in snoring, and this was evident in 95% of the patients, whereby the snoring had reduced by 48% or more. In the mild OSA group, that's in the 38 patients, the AHI had reduced, the ODI had reduced, and the Epworth Sleepiness Score had also reduced. And these were all found to be statistically significant. The subjective visual analog score by partners also confirmed improvement. Next slide, please. So this demonstrates the bar chart here on the AHI, the ODI, and ESS, where P was less than 0.01. Next slide, please. So this was the data that we produced in the multicentral trial between UK and Spain. We had 115 participants. And then again, there was 90% reduction in objective snoring and mean reduction. So this was, again, statistically significant. The Epworth Sleepiness Score and the Pittsburgh Sleep Quality Index were also reduced significantly. Next slide, please. So of the 115 patients, 65 had mild OSA, and the mean body mass index was 27. One of the exclusion criteria was BMI of greater than 35. We thought that because of the fat spaces in the neck and the tongue base, perhaps this device might not be suitable for them, but we can try. So I'd just like to finish off with the role of Excite OSA in my practice before I hand over to the next speaker. I believe that there is a primary role, and although I don't work in the NHS at present, it's probably quite useful to think about this in the NHS mainstream, where patients have been waiting for such a long time for studies and treatment, and perhaps it may be prudent to offer the Excite OSA to these patients whilst they're waiting. And although it's not available in the NHS, maybe the clinical commissioning group that Mr. Haidas had alluded to in his paper that I mentioned earlier on should be approached and get this recognized. So I use this as a primary role in my patients with BMI less than 35 who do not have a tonsillar hypertrophy of greater than size 2. And if I consider surgery for them and they have residual snoring, then I use it as an adjunctive or an adjuvant therapy. So I think that there's a huge role for Excite OSA for global use, and certainly it would be a very useful addition to the NHS mainstream if this is possible. The beauty of this device, of course, is that the patient do not have to use it during sleep. They use it whilst they're awake and only for 20 minutes. They use it for 6 weeks, and then they can maintain it for twice a week as a maintenance for the tongue tone. So I believe that this kind of device is widely available, easily available, and affordability is there. It's not as expensive as surgery or the Inspire device. And acceptability, the patient tolerance, patient acceptance is really great. So, you know, there's 86% or so adherence. And I think that's quite a good data compared to CPAP compliance or adherence and the mandibular advancement device compliance and adherence, which is probably around the 60%, 70% mark. So that, ladies and gentlemen, concludes my presentation. And I'm now going to introduce Dr. Aditi Desai, who's a dental surgeon, she has a huge experience under her belt. She's been the president of the dental section at the RSM. And without further ado, Aditi, the floor is yours.
Thank you, Rick. Let me see if I can get my share screen. If you unshare, that'd be great. I can actually share my screen now. Yep, there we go. Wonderful. Well, thank you very much, Vic, for that introduction. So this is me, and these are my appointments and disclaimers for anyone who wants to know. But I'm not going to waste any time on that. I'm going to talk about the evolution of sleep services from a dental perspective. So the awareness of sleep quality and quantity has never been more heightened than now. Is that a result of COVID, or is it a result of technological innovations, things like Fitbits, Apple Watches, and others, which obviously we're going to be talking about, the topic of discussion today? We're aware of the publication of the new NICE guideline in 2021 August, which has further highlighted the contribution by healthcare professionals other than physicians. Up to now, it's always been in the arena of the physicians, ENTs, respiratory consultants, neurology, but now I think that they have highlighted there's a lot more that can be done as part of an MDT, multidisciplinary team, where dentists, physiotherapists, psychologists, all of them can come into the field and help contribute towards the optimized pathways. Now here I'm also going to mention PIFU, which is the patient-initiated follow-ups. It's a great way to deliver care to many. Now, why has this now come into the fold? Is it as a result of funding, or is it because we want to now use technology to minimize costs through reducing face-to-face manpower? So people having to come into clinics, hospitals, to have a consultation, but now we're leaving it to the patient to say that in certain areas you can actually call in, or you can have a teleconference in order to get the care you need. So that helps them not have to travel in, helps us from not having to have clinic time and space, I guess. So the NICE guideline, I'm going to actually focus a little bit on the oral appliances, which have for the first time been acknowledged in the NICE guideline in the NHS. We're working very hard, in fact, to get a pathway up and running, which becomes a nationally accepted pathway and with funding. Now, the acknowledgement of the OSA, oral appliance therapy, is still remains second-line therapy, and it's been a long time coming. So this now brings me to mention to you that if these patients are going to be seen, then if they are going to be, seen for mild disease, moderate or severe disease, they will still be given a CPAP as the first-line therapy, and oral appliances will then be second-line. Now, with the high CPAP failures, it may be 50%, 20%, 10%, whatever it is. But if you look at 20% of 2 million people in this country, for example, that's a lot of patients that need help. And with the latest Philips CPAP debacle, I think more needs to be done. And now with the acceptance of oral appliance therapy, as even if it is second line, I think that's a win for everyone. For me, I find that while working with my medical colleagues, the MDT, I feel so much more confident because I know that if I need help, I will always have my colleagues to lean on, or they can always ask me for help, because that means that these patients are going to be, we will be delivering the best optimized care to them. And that for me is also an important factor. And of course, with the NICE guideline, it has also acknowledged the use of combination or adjuvant therapies. So what is going to happen to these patients who are asymptomatic and who are at the lower end of the spectrum of disease? The NICE guidelines suggests that these patients who are not symptomatic should not be offered therapy anything more than lifestyle or sleep hygiene or perhaps even positional therapy. That's all very well, and that's absolutely fine. However, what happens to these patients who are snorers? If they're intrusive snorers, what happens to them? What do they do in order to seek help? Do they always have to go into private care? Maybe, maybe not, I don't know. But the effect of this snoring is not just for themselves, it's also for their bed partners. And once a bed partner is out of the bedroom, it's a very slippery slope. The patients themselves do suffer with psychological issues. The embarrassment of snoring, not being able to be socially active when they need to go and spend time in somebody else's home or in a hotel room. So, for us, we do need to take a, note that these patients need help. Now, while the NHS post-COVID is struggling to prioritize funding, new therapies like the Excite OSA, I'm just going to say it's Excite OSA, are important additions to my armamentarium for sure, but certainly for the physicians and all dentists. The dental role is absolutely pivotal in this. And NMES is affordable, practical. It's a very practical therapy that requires no impressions, no scans, no technologists, and not many visits to initiate treatment. With oral appliances, of course, I'm not going to talk myself out of oral appliance therapy, of course, because that's what I do, but there is a pathway that one follows. They come in, get assessed, then they might have impressions or scans done, then they come back for fitting, then they have to be reviewed, they have to be titrated or fine-tuned to get the best outcome for that treatment. With Excite OSA, it's a one-stop shop. Now, the role of dentistry has certainly evolved. This is as a result of education and awareness. And I think people have become more aware of what they need. And by creating that need, the education and the awareness comes in. And therefore, the role of dentistry has certainly evolved, at least ever since I have been in the business of sleep medicine. It's absolutely imperative that appropriate patients are selected for appropriate therapy depending on their phenotypic pathophysiology. Now, the benefits, potential risks, and limitation of oral appliance therapy are evident. And again, like I said, I'm not going to talk anyone out of providing oral appliance therapy because that's what I do. But I know that occasionally, depending on the patient's phenotypes, we do need adjuvants and we do need a bit of help, to start off the treatment or finish off the treatment. So we know that we need to get a bit of help on this. And while oral appliance therapy is a credible alternative, it's no longer the severity of disease from an AHI point of view that determines who gets CPAP and who gets oral appliance therapy anymore. It's all based on symptoms. So whether a patient is mild, moderate, or severe, but if they have symptoms, they will be offered CPAP. But the lower end of the spectrum, we know that the milder patients, they do not want CPAP. They try to avoid CPAP if they can, especially when they're younger people. So while oral appliance therapy is there, let's see if we can give them even simpler treatment options. So I was introduced to this novel technology some 2.5 years ago. So I saw a place for it in the sleep apnea ecosystem immediately. It was beautifully packaged, incredibly, I was so impressed with it. I just suddenly thought, this is something, if it works, this is exactly what I need for my patients. And oh my God, for those resistant patients who have the oral appliances, they do really well. And you'll hear probably from the following speaker that the patients who are at the milder end of the disease spectrum are much harder to treat than those at the more severe end. So I knew that this is something I would like to try. So I started trying this myself, and I tried it on some of my patients, and I came back with some very good feedback. So my patients reported saying, they're sleeping better. They're sleeping so much better when they use it the last thing at night before they go to sleep. However, they did say they drooled a lot, but then, you stick a lemon drop in your mouth and you will start salivating rather a lot. So I said, get over it. But then they also said, I cannot feel any difference and it feels strange, or my ears are ringing. These are the comments that I was getting back, and I was, calling up the support team and saying, what about this? What about that? So I have learned over the last 2.5 years. So this comment, it feels no different. That's interesting because the tongue is not meant to feel different. It just is and starts getting different. So it's not going to start jumping or, somersaulting at all. It just becomes less fatigable. I wouldn't even say stronger, because stronger means you'll feel the difference, but it just becomes less fatigable. The changes are incredibly subtle, but the sleep quality does improve. Drooling is temporary. Adherence is essential to benefit from this therapy, but there'll always be patients who won't respond to this therapy, but then they may not respond to any therapy. It all depends on whether the glass is half full or half empty. But you will always have any therapy at all. We are well aware that medicine is not exact. Science is not exact, so you will have responders and you'll have non-responders without any rhyme or rhythm. So I'm going to actually now go through just a couple of real-world cases. These are my patients that I've treated. So patient one, he came in, he was 36 years old, a skeptic. He did not want to be where he was, sitting in my consulting room. He was, disinterested, but he felt that he was such a heavy snorer and his bed partner was getting rather irritated and threatening to leave the bedroom. So he came in for an oral appliance because he did not want to try CPAP either. He wasn't an apneic, he was just a snorer, but rather an intrusive snorer. So I said to him, if you're so resistant to an oral appliance, let's try the Excite OSA. He said, no, this has become too serious for me. I will have the oral appliance. I don't want it, but I'm going to have it. But while I'm having it, I'll try this as well. And I'm really pleased that he did, because this gave me the best feedback I needed, from a patient. But he did not come back for fit of his oral appliance for 4 weeks, just over 4 weeks. But when he came back, he said that his snoring had reduced so significantly that his bed partner was willing to tolerate it with earplugs occasionally. Now that actually made me think, my heart sank, thought, I've got this oral device now, what am I going to do with it? However, once I explained the pathophysiology of the of sleep disorder breathing and how it can worsen over time, the continuum of disease that can get worse with age and weight, he sort of reluctantly took his oral appliance. And then recently I had a telemeeting with him, and he stated that he wears the oral appliance when he has drunk a lot, as he starts snoring a little bit louder, but uses the Excite OSA regularly. Now that is very good positive feedback. Patient number 2, he was referred to me for an oral appliance by an ENT consultant, not big, I'm happy to say, who had originally recommended an off-the-shelf appliance. That again makes my heart sink. So this gentleman wore this device for a rather long period of time. He had noticed that his bite has changed, that he's had an open bite, and he had developed a lisp. Now, this is what he reported to me, because I obviously hadn't seen him previously. He also said to me that he had started snoring again. No matter how much further he titrated the device, he had started snoring rather intrusively again, and he was experiencing jaw ache. So I decided that I was going to make him a bespoke device. However, I would like him to try the Excite OSA. And once he came back for fitting of the oral appliance, he said to me, I don't need to wear this oral appliance anymore because the Excite OSA has completely stopped my snoring. Now this is within 3 weeks. So his wife was incredibly pleased with me, and he felt pleased that he did not have to wear the oral device at all, which is great. But the icing on the cake for me was, because he did not have to wear an oral appliance that was going to protrude the jaw, we had a reversal of his bite changes, and his lisp has gone. So for me, I feel that I've treated 2 for the price of 1. So for me, these are the 2 real, these are not the only 2 successes I've had with the Excite OSA, but we haven't got much time. So my practice protocol is that unless contraindicated, as in Marc's presentation shortly, every patient who comes in to consult with me receives an Excite OSA while initiating oral appliance therapy, or if I feel that they're not too severe with their snoring or OSA, I will give them the Excite OSA as primary treatment. But it's a decision that I can make on the spot. Therapy therefore starts immediately. Once the device is fitted, they will still continue to use the Excite OSA and wear the oral appliance. I find that in some instances, when I predicted a certain incremental protrusion or the fine-tuning of the jaw to get them to stop snoring and control their OSA, the titration is a lot less than I predicted. Now that in itself is a win, because that means that the less you protrude the jaw, the less likely you are to get any complications as a result of the oral appliance. Now, this is clearly the adjuvant potential with this daytime therapy. I just think that the two together are a great combination. Now, those patients who present with unsuitable dentitions or raging periodontal disease, we all of us are probably familiar with the NICE guidance. It says that oral appliances are not suitable for people with periodontal disease, compromised dental health. However, I agree, disagree, irrelevant, but for those people who have no teeth, for example, or who are, have raging periodontal disease, you get them feeling better, and you find that it'll help while they go and seek dental care. So by virtue of what I do and teach, oral appliance therapy will always remain in my toolbox as primary therapy for what I do. But those patients who cannot receive care in the NHS because of the numbers that are rising, who cannot afford a bespoke precision oral appliance, I mean a precision oral appliance, which is actually a medical device, this is a very good alternative compared to providing cheap, unsuitable dental anti-snoring devices. And when I mean dental and medical, we are trying to treat not just a dental condition. It's not a dental condition, it's a medical condition that needs medical interventions. So with that, I'll say thank you. I've never been happy to see anyone, Mark.
Oh my
Perfect.
gosh. You can hear me, amazing. I apologize for any difficulties here. I'm from America. I spell apnea incorrectly, and apparently I cannot operate Zoom. So this is why I had children. Next slide, please. The US experience, just in general managing sleep, it's going to be operationally similar to what you're experiencing in the UK, but we have obviously different access, different insurance issues, and a variety of logistics that are somewhat different. So I'm going to give you the US perspective from what I've had, which is reflective of what's going to be the case with a lot of providers. And this will give you guys some insight as to what a busy practitioner might be ultimately encountering moving through the process of integrating this into practice alignment. Just as a quick update or a background on my experience, I trained in the 80s. I was one of the early people doing sleep in the US. Was part of a big medical group for a number of years and did both the pulmonary critical care and the sleep. Had the opportunity to open up a small practice in 2009 to 2016 and had the luxury of putting together a very elegant little arrangement with a nice sleep lab, sleep coaches, sleep navigator, and the ability to provide a very, very finely tuned product, which unfortunately was not sustainable financially or operationally due to the way things have evolved here. And more recently, I'm part of a very large medical group. We have 9 or 10 board certified physicians in this group in sleep alone. And I personally see about 500 sleep patients per month. I'm managing about 2,000 patients with sleep apnea. And the basic understanding that I try to establish with my patients, if you see me for a sleep disorder, my job is to find you a solution that works, that you can tolerate, that you can do well with, and you can be satisfied with. We also do quite a bit of our work on telemedicine these days. I'm not sure whether you guys have been pushed into a situation where that's either available or necessary, but between COVID and the technological advantages, we do a lot of sleep via telemedicine, and sleep is very well adapted to that. Okay, as far as, next slide, please. In terms of the therapies that we have currently available, the insurance platforms here are very different than what you're dealing with. Almost all of them cover PAP therapy. In some cases completely, in other cases because of copays and deductibles, it can be fairly onerous for the patients. Oral appliance therapy, which is the most expensive of these options, typically runs from $2,000 to $7,000, including both the device and the scanning and the chair time. And some insurances will cover it, many don't, and the patients have a widely variable and often predictable experience in terms of what this ends up meaning to them financially. The Excite device in its current situation is $750, which is an all-inclusive fee. It's been available in the US for a year, and as of about a month and a half ago, they obtained a unique billing code for neuromuscular electrical stimulation for the treatment of sleep apnea, which previously was not available, therefore there was no billing code. And in the US, if there's no billing code, there's no billing through insurance. Typically, insurances will eventually move to adopt this, and the expectation is, in all likelihood, later this year, this form of treatment will be reimbursable through insurance. Typically, the expense is passed to the patient at this point, $750, and it is distributed through any of a variety of local medical supply companies. Typically, the physicians cannot directly disperse them because of regulatory issues. And the policy that we have here is that if you use it for 6 weeks or less, and you are either unsuccessful in your efforts to improve your situation or you do not tolerate it, a full refund is available from the company for the patient, which is very appealing and certainly allows us to, in many cases, get past the lack of insurance coverage. From the standpoint of how long it takes to get treatment actually initiated, because of the supply chain issues, because of the massive recall of CPAP equipment, and then because of insurance issues and all the other impediments involved with delivering care, it typically takes 2 to 4 months before PAP therapy can be successfully initiated. I should say initiated, and successfully initiated obviously may take longer if there's issues with masks or the equipment. Oral appliance therapy typically takes about 1 to 3 months to get from the beginning to at least a point of treatment. And again, scanning, creation of the device, customization, and then insurance issues often delay this. Excite can be delivered and initiated within a few days to a week or two in almost all circumstances. In my experience in this practice, over the 10 months that this has been available, it's been offered to a significant percentage of my patients, both in the mild OSA range and also a significant number of patients who have less than mild apnea but have intrusive snoring, which is a very common complaint that we have to deal with. And it's a problem that we typically don't have much of a solution for. About a third of the patients who are ultimately started, I put them on the therapy at the time that I reviewed their initial sleep study, told them what was going on and what the treatment options were. About 1/3 of them, I ended up having the discussion with them, laying out a number of options, and typically referring them to the Excite OSA website and to other resources so they could come to a decision as to how they wanted to proceed. And a significant number of them decided to move forward with this treatment. And about 1/3 of these patients were people who had circled back with me, because I do tend to follow all my patients over time to the extent that I can. And these are people who've had unsuccessful experiences with other modalities of treatment or had opted not to pursue treatment. But once they were aware that this was an option for them, a number of them came back and were then interested in starting treatment. Like Aditi, I want to go through a couple of cases. So if we can go to the next slide. First case, and these are obviously going to demonstrate cases where we've had some success. There are certainly some cases where you don't see success, but we're seeing in our practice, a significant number of these people see something between incremental and significant improvement. So I just want to lay out 2 pretty typical cases for you. One is a 53-year-old postmenopausal female. This initial consultation was done face-to-face. Normal BMI, mild hypertension, nocturia, no other major problems, family history of sleep apnea. And basically the issues were the snoring was creating problems at home, and her physician had expressed concern as to whether or not sleep apnea could be contributing to her hypertension, which was the main reason she was referred to see me, along with the snoring. She underwent a home sleep test, which demonstrated loud, persistent snoring, fragmented sleep quality, an AHI of 8, and a respiratory disturbance index of 13, and her apnea was not positional dependent. She had minimal hypoxemia. I reviewed the results with her during a telemedicine visit, which has been a lot of the follow-up visits we do have been telemedicine. The patients really find that to be convenient. And I laid out for her the standard options in this situation. She ultimately decided to proceed with the neuromuscular electrical stimulation option, understanding that if this was not successful, we could theoretically go to one of the other choices. She returned to see me 3 months later, which is typically the interval that I recommend people wait before they come back to see me. She had been using it quite regularly, according to her. She had noticed a significant reduction in the snoring, which improved things at home considerably, and she was very happy about that. Her blood pressure had remained well controlled on minimal medication, and subjectively, she felt that her sleep quality was better. Overall, she had no complications. She was very satisfied with her experience. The second case, 28-year-old male. This was initially done via telemedicine. BMI elevated. He was going to the bathroom once a night, had borderline hypertension. He had been found by another prescriber to have mild sleep apnea about a year and a half earlier, with an AHI of 11, RDI of 14. As is commonly the case with initial therapies, at least amongst the sleep medicine personnel, he was started on an auto-PAP trial. He tried it for 3 weeks. He had problems with the mask. He had problems with the pressure, didn't make a tremendous effort, could not acclimate, and ultimately returned the equipment. He came to see me 18 months later because he had more problems with the snoring, and he just was looking for another solution. I reviewed the situation with him in detail, gave him a couple of different options, and ultimately he decided to proceed with the Excite device. We also talked about some lifestyle modifications, including weight loss, keep cutting down on his alcohol intake, and possibly repositioning himself at night. He came back to see me 4 months later. This guy was extremely excited. He was doing quite well. He was sleeping better. He was back in the bedroom. He was compliant with therapy, which was based on what he told me, and the cloud-based tracking option also facilitates that information if you're interested in pursuing it. He had lost some weight, he had reduced his alcohol intake, and overall he was doing very well. He had some concerns about what the impact of long-term sleep apnea might have, so we decided to repeat the home test. So this was done about 21 months after he was originally tested. And at this point, his indices were about half of what they were originally. The AHI had dropped from 11 to 5, the respiratory disturbance index from 14 to 8, and to the extent that you believe the snoring reports on the home testing devices, there was a reduction in that. So he's going to continue on therapy, and he'll be seen by me every 6 to 12 months and follow up moving down the road. Next slide. So the pros and cons I'm going to talk about from the perspective of the patients. First of all, this option is appealing for people who do not want to or have failed PAP therapy or oral appliance therapy. This is another option legitimately available now for the mild sleep apnea. Nothing's worn in the bedroom. And for people who have issues with claustrophobia or bad bedroom optics, or simply walk in and the first thing they say is, I don't want that mask. Well, this is certainly a way to get around that, whether they've had the experience or whether they just are concerned about it, what could happen. In order to get treatment started, we can do this much more rapidly and get to the point where patients are likely to see tangible results than would be the case with the other treatment options. This is extremely simple for patients to use. It's much easier than dealing with CPAP and the acclimation and the maintenance, and then trying to understand where you are and how to deal with your problems. The phone app is very well designed and facilitates both initiation and moving through the treatment process. In the absence of insurance coverage, the return policy is very appealing. The cost of treatment is, even in the absence of insurance, is probably as low or lower than most other of the treatment options. Unlike PAP therapy, you don't have to worry about mask leak, mask discomfort, air swallowing, the inconveniences associated with traveling with a CPAP device, the seemingly endless nasal and sinus complications that are often exacerbated by CPAP or can evolve once therapy is started. And then we certainly see some incidents of complex apnea, even in the milder patients, which is not likely to occur here. And it's not anything that I'm aware of at this point, but I'm sure that'll be looked at. Unlike oral appliance therapy, you don't have to encounter the discomfort, the intolerance some patients have to putting the appliance in their mouth in the first place, the evolution of bite abnormalities, or the excessive salivation that occur with appliances. In terms of, next slide, in terms of the issues for patients, it's not reimbursed by insurance yet. There's no guarantee of efficacy as monotherapy, as was discussed by Aditi, and it's not compatible with braces or extensive metallic bridge work, depending upon the patient. A small number of people in my experience have had difficulty using the device. I actually want to skip the rest of this slide and go to the next one because I arranged things a little bit differently. I want to discuss it as such. The impact of neuromuscular electrical stimulation option now for patients who are practicing sleep medicine. The positives for the providers. Number one, those of you who deal with a lot of sleep patients, mild sleep apnea is very difficult to treat successfully. In many, if not most cases, I find it harder to treat than severe apnea, where the solutions are more limited and the treatment impact tends to be a little bit more significant early on. Here, with the milder patients, they often require customized solutions. Oftentimes, treatment adherence is low. Patient motivation is often quite variable. And this really fills a void that previously existed in terms of treatment options in the setting. Everything about NMES is easier, faster, more convenient. It's much easier for the patient. It's a heck of a lot easier for the office staff and for the providers in terms of the paperwork, the logistics, the timing, the communications, and the opportunities for people to fall out of the system because things don't happen correctly. When things don't go quick, or there's financial impediments, or there's other unexpected complications, it's where you see a lot of your treatment dropouts and a lot of your customer dissatisfaction. The lower cost and the greater accessibility is going to open this up to be available for more people than our current options are. And in the setting of providing virtual care, and again, I don't know how much of this you're doing on the other side of the pond, but over here, we're doing a fair amount of it in sleep, and administering this type of solution via virtual care is much easier. And in our practice, in addition to offering treatment like the Excite device, we do it oftentimes in conjunction with other modifications of lifestyle behaviors, and we've seen that it increases patient engagement, and it's gotten us into a better place with regards to the patients participating in the process. If we can go to the next slide. The issues for providers, again, lack of insurance coverage can be a problem, and it does require that you have to have a conversation that figures out how to address this. And also the statement, which I'm just going to reiterate, that this is not necessarily effective monotherapy for everybody, and it may be better administered in combination with other types of treatment. The work to be done here, the progress that we're also looking to see, is in further studies that will compare, first of all, the health economic outcomes for NMES for sleep apnea versus what we see with PAP therapy, oral appliance therapy. That's in the works. Identification of different sleep apnea phenotypes who are more likely to benefit from NMES than others to allow us to be more accurate in our patient selection. And then finally, determining whether NMES in conjunction with other modalities of treatment could be useful. The bottom line is that for practitioners, Excite is a new and very welcome tool in the sleep medicine toolbox. It makes it even easier for us to offer a full spectrum of effective solutions managing this incredibly common and intrusive disorder. So thank you. That's the end of my presentation part here.
Thank you very much, Marc. And I'd like to thank both Marc and Aditi for their excellent presentation. I would like to apologize for the technical issues that we've had. So we have a few questions, but I'd like to summarize what we've said already. We've talked about neuromuscular electrical stimulation in OSA, specifically useful in mild OSA, but I must also point out that there have been studies that have already been designed and being conducted as we speak in the United States on moderately severe OSA, and randomized control studies, double-blinded control studies. So a lot of data is going to emerge shortly. So we have a few minutes for questions, but can I assure you that any questions that you've typed in, if we don't get time to answer them, we will get back to you by email. So the first question here I've got from Louise Piers. asking about data on utilization of the device. So is there any way of us tracking this down? Perhaps, Marc, would you like to talk about adherence and compliance in your patients?
When these patients register their device through the home care company, there is the capability of identifying how frequently they're using the device and how compliant they are with it. However, that data is out there. So much like we have the ability to track compliance with PAP users through the various cloud-based applications that exist, and hopefully in the next couple of years, we may have similar technology emerging with the oral appliances as they become capable of that. You do have the capacity, particularly if you're able to close that loop and make sure that these patients are properly registered, to identify how compliant they are with the equipment.
Thank you, Marc. I think Rebecca wanted to know how much the device costs in the UK. I believe it's £540 from the company. So there were a couple of ENT questions which I'm happy to take on. The first question was from Mr. Shahzada Ahmed, saying that he uses Excite OSA in the private sector but doesn't know how to convince the clinic commissioners. So to that, Shahzada, I would say that we have got 3 or 4 papers that are already published, but as we speak, there are randomized control studies being conducted in the United States, and when those come out, I think the CCG will be convinced by that. Also, we have had a couple of posters that we presented at a meeting looking at the health economics, and we looked at Excite OSA versus no treatment and Excite OSA versus CPAP therapy. It was both favorable in terms of the Excite OSA. This was purely due to the fact that with CPAP and the mandibular devices, the compliance is not very good, whereas the adherence with the Excite OSA is more than 85%. There was another ENT question which I'll take, is from Mr. Yusuf Salim. Do we need to know the level of obstruction of the OSA before we start the patient on Excite OSA? So Yusuf, I would say that if you have a patient with gross tonsillar hypertrophy, grade 3, grade 4, there's no point in using Excite OSA. But majority of the patients will exhibit a multisegmental phenomenon. So in most patients where the tonsils are not large and the uvula is not that large, I would suggest that you try this as your primary treatment option if they haven't got moderate or severe OSA.
Vic, let me break in on that for a little bit, because along the lines of what we talked about, ideally, if we are, as time passes, getting that as a formalized, being able to identify that as a clear cut or at least a much more likely phenotype to be responsive to this kind of therapy, I think that would be a very strong positive on behalf of this, to allow people to select their patients. Looked at in the research context, but certainly people like yourself who have that kind of expertise and understanding of the anatomy, it's a very good guideline to start making decisions at this point in time.
There's also another question: does this therapy hurt? So Aditi, would you like to comment on this? That do your patients complain it hurts?
No, I've had no hurt mentioned. People will complain about drooling. They might complain about, the problem of holding it in your mouth. But then you have to teach them how to actually manage it in the mouth. If they're trying to hold it with their lips pursed, then they do find it a little bit difficult. But no, I've had no people complain about hurt at all. Maybe a little bit of tingling, maybe a lot of drooling, like I said. Sometimes they think that, they don't really know how to seat it. So you have, once you show them what to do, then they go away quite happy. But no hurt at all.
Yeah, so I agree. And also the drooling and the tingling I've found is only during the duration of the treatment for 20 minutes, and thereafter it settles down quite nicely.
Yeah, I think one of the questions that I've been asked is when they've had implants or they've got gold or amalgam fillings, they said, well, do you think this is going to electrically shock me? And I said, no, I don't think it will, because the current is quite mild. So no, I've had no other complaints, no.
Yeah, and I think the pacemakers in pregnancy are the 2 contraindications that you've suggested. Yeah. There was another ENT question from Manuel Casale from Italy, asking about the use of it with patients who had barbed pharyngoplasty. Is there any issues with that? Well, I would suggest that as an adjuvant therapy, it's quite useful in any kinds of surgical patients where there's residual snoring. And that's now my standard practice, because surgery will not cure 100% of the snoring. So it is very, very useful in these patients. And this is a large number of patients that will be suitable for it.
Yeah. Vic, there's a question on here about the cost that we've addressed.
Yes.
But we need to make that clear that, there's with or without VAT. So they might need a little bit of clarity on that.
I think my understanding was that the VAT has now been removed in the UK, so it is 540 total cost. Is that correct, Travis?
That is correct for chronic conditions. For snoring, it is with VAT. So if you're purchasing it directly for snoring.
That's right. That's right. I think they have to tick a box, don't they, to say it's not for snoring, it's for OSA. And if it's for OSA, they don't pay the VAT. But if it's just for snoring, then they do pay the VAT.
Okay, and there's a question from Rebecca. How often do you have to replace the mouthpiece and how much does that cost? I think the replacement of the mouthpiece, I think it's about 3 months. In my patients, I found it's about 3 months.
Yes, it's about 3 months, yes.
And the cost of the mouthpiece is about £30 or so. I'm not entirely sure. I think it's around £30.
I thought it was about 50, but I might be wrong. I'll leave that to Travis to answer.
10% of the kit price. So right. when you start off at 540, you can do the 10%, 54.
£54. Okay. Okay. There was a few more questions coming in now. Just to ask you, how effective is it in craniofacial anomalies such as long face syndrome? Aditi?
I don't think this has anything to do with the long face syndrome whatsoever. It's purely a tongue stimulating device. So it doesn't matter whether the face is long, short, it doesn't make they have anterior open bites, nothing at all. So I think they'll be quite happily, be successfully treated with Excited OSA.
Yeah, and I think anatomically, this is for my ENT colleagues, the gentleman who asked about the barbed pharyngoplasty, with the toning of the tongue muscle, the genioglossus is the largest tongue muscle, but I'm sure that if you look at individual muscle fibers, it's probably stimulating that because of the placement of the fibers, placement of the electrodes rather. So even the palate, the palatoglossus muscle is attached to the tongue. So if the tongue in itself tightens and doesn't retract as back posteriorly, then it surely will help the other anatomical segments as well.
Absolutely. Yes, it does.
In interest of time, ladies and gentlemen, we've gone past the hour mark. First and foremost, thank you very much to all the participants for taking time out in the sunny day in the United Kingdom, certainly. And thank you to Dr. Aditi Desai and Dr. Marc Benton. And many thanks to Signify, Travis, and the team for arranging this symposium, the webinar, which has been very useful. So thank you very much. And we will get back to you with the answers to the questions that we've not tackled so far. Thank you and goodbye.
Thank you, everyone.
Thank you, everybody.